icon. If you could click that and then click the upward thumb if you can hear me and see me okay. So I just want to confirm that video is clear and that audio is clear. Okay, I have a few people that have responded. If I could just get a couple icon in the left-hand portion of the screen, about midway down the screen.
Yeah.
Thank you. I'm just going to turn off video for a second. We'll be going live very soon. Hi, good evening, everybody.
We've started.
Okay, we're getting underway. Thanks, everybody, for coming tonight. We're together at the Mewett Classroom at Court of Cardiology. My name is Bill Hughes. I'm a cardiologist. With us, we have several family health teams, Bancroft, Halliburton, Campbellford, assembled at their buildings, joining us by webinar, and a number of individuals joining us by webinar from the region. I wanted to acknowledge that we have received unrestricted grants from Bayer, Servier, and BI. This series, they were not involved in any way in the planning of topics or the selection of speakers, and we're grateful for them to help us in that way. There are 6 events in the series. This is the first. Some of you have signed up for others and might consider. The format is going to include a couple of short presentations before most of the major sessions. So we encourage you to get in touch with us at cme@vhn.ca with any ideas that you have. So we have basically, between now and the end of the series, 75 minutes of uncommitted time in 5 to 15-minute sessions. So if you have things that you want to talk about or ideas, let us know. I wanted just to remind everybody, most of you may know, but some may not, we do have a new service with the VHN, and that's the atrial fibrillation clinic. Our nurse practitioner, Bev Hill, coordinates that program. And it's functioning essentially the same way as the chest pain walk-in clinic, but we're doing that for atrial fib to get optimization of anticoagulation. So you can reach out to Bev at her VHN.ca email, or just call the IGMC office. We're here in the James Mewett classroom. Jim Mewett was a pioneering surgeon in Peterborough. He introduced vascular surgery to Peterborough, and he introduced vascular imaging. So it's been our honor over the years to run our educational events in this room. And just for those of you out there in TV land, just so you can see where we are, this is the interior of the classroom. And I'm going to turn it over now to Dr. Hartlieb. Tonight we're going to do a lot of navigating things with compasses and various other things, but Mike's going to start us off helping us to orient ourselves to those fiber oxide band. Mike?
Okay.
It takes me a second to cue you.
You do your thing.
Thanks.
Good. Okay, everyone. Good evening and welcome. So I've been asked to talk briefly about Compass. Bill said we've got 75 minutes of uncommitted time. I'm going to take about 69 of them tonight just to go through Compass. So this is going to be a challenge for me because many people in the audience have seen me give talks before. People outside have also seen me give talks, which means you will still see me, but you will not. So I will try very hard to stay in one place and talk, and it's going to be a challenge. We're going to talk briefly about Compass, and I mean briefly because it's a complex trial. It's an interesting trial. It's going to be useful for our patients. And to do it justice really would take a fair bit of time to go into the details. But I want you to be aware that we are starting to use this regimen in our patients. You are going to see it in your patients, and you are going to be asked to use it in your patients. You're going to have people come give you talks about Compass, also with me. And so I want you to have some broad strokes to think about before that occurs. Disclosures, as always, for what it's worth, I was an investigator in the Compass trial. We had a large number of patients in Compass. So there you go. Background. Risk for recurrent cardiac events in folks who presented with vascular disease is not zero. It's in the range of about 10 to 15% per year, and that is despite modern, contemporary, aggressive medical therapy. And the goal continues to be to try to lower the bar, lower the risk for our patients. Why are we thinking about the COMPASS trial? We actually have therapy in folks with vascular disease is beneficial. The ATLAS trial looked at a regimen very similar to COMPASS in post-MI patients, and in fact demonstrated benefit, but was challenged by bleeding. And so it was the ATLAS trial that made us think, well, let's use it in stable patients with vascular disease and see if we can actually lower risk for our patients. So this was designed simple, large, about 28,000 patients with 3 groups. Really, the comparator is aspirin, which would be what we would all consider using in our stable vascular patients. The 2 arms that were compared were rivaroxaban 2.5 BID and aspirin, so low-dose rivaroxaban, or rivaroxaban 5 BID, remembering that the anti-thrombotic therapy for atrial fibrillation is about 20 milligrams, or aspirin alone. Typical COMPASS patient, 68, 90% of the patients had coronary disease, 62 with prior MI, so it's a pretty sick group of patients. A number of them had peripheral arterial disease, and we'll talk about that in a second because it's actually really a big headline for COMPASS as far as I'm concerned. Really well managed medical therapy. You can 90% lipid lowering, 70% ACE and ARB. So really good contemporary data. This is the headline of the trial. So if you look at patients who had peripheral arterial disease, which could get you into trouble or into the trial, coronary disease gets you into the trial, and look at outcomes compared to aspirin, there was a very statistically significant relative risk reduction for major adverse cardiac events, which classically is the stroke myocardial infarction, 20% in both arms. So that's the headline. This works, it's effective, it lowers risk for patients compared to aspirin monotherapy alone. Let's delve into it just a little bit more. There's something on this slide that's actually important to mention and I want you to focus on, which is what we would call the placebo event rate. It's not placebo, but the aspirin event rate in the folks who have, most of the folks who have coronary disease. We're talking about adverse cardiac event, and you'd think that the folks who have coronary disease should by definition have a higher risk. Not the case. In this trial, and in many trials, it's very clear that folks who present with peripheral arterial disease are at increased risks for adverse events of all types. We have, to this point, underestimated, I think, the risk of influence outcomes inclusive of heart attack or stroke. This trial, like many recent trials, clearly demonstrates a very high-risk population here. We can focus on what this trial called major adverse limb events. We understand major adverse cardiac events. Major adverse limb events is a composite of angioplasty, bypass, amputation, thrombolysis. And it's notable, and they can tell you what their risk is. You don't have to go too deep in. But we know someone who's had stable coronary disease, they've not had an event for over 20 years, they're not the same risk as somebody who just came out of the hospital with acute coronary syndrome. Similar peripheral arterial disease. If you look at outcomes in folks who really just have defined peripheral disease because you did an ultrasound or you did an ABI, and you compare outcomes to those who just had a revascularization, not surprisingly, depending on how you're presenting with your disease. If you're asymptomatic, your risk may be here. If you're symptomatic, you require an intervention, you're at a much higher risk. And it's very true in this trial as well. As patients became symptomatic or presented with intervention, the risk of an outcome markedly increased. Your patients will tell you what the risk is simply by history, possibly clinical exam. Why does this matter? This is what happened to patients in this clinical trial if they had peripheral arterial disease and they had an event in the trial. So they had peripheral arterial disease and they had an intervention, or they needed thrombolysis, or they had a limb on. What happens next? In the trial, subsequent hospitalization, 97.2 times increase, hazard ratio. Vascular amputation, 100 times more probable that you're going to have another event, including vascular amputation. All-cause mortality markedly increased. We significantly underestimate the risk for folks who have vascular disease in this trial. As far as I'm concerned, one of the major headlines is when these people present, they present in ways that tell you that they're going to get into trouble in the future. The good news is that this trial clearly demonstrates that if you use this strategy in folks who have peripheral arterial disease alone, they benefit in a very significant way. Major adverse cardiac events down 20%, myocardial infarction, very impressively stroke, 50% reduction. We're going to focus on major amputation. You can look at the rest if you want. 70% reduction, 70. There's nothing, small numbers, but 70% reduction in the risk of having a major amputation in folks who have disease in this trial. Luckily, we have some subgroup analysis and relevant to Dr. Tobe. In folks who have renal disease, with or without, benefits are the same. Risks are not particularly worse. Of course, it's thrombotic therapy. And so the risk of amputation, and to be fair, is a hazard ratio of about 70%. 1.7 times increased risk, major bleeding in the folks who are exposed to the active arm in this trial. What does that mean? It means primarily GI bleeds primarily in the first year of the trial. Bleeding-related mortality did not increase. So these are what the authors would like you to believe are nuisance bleeds. That may be true if you're... These are primarily GI bleeds. What's interesting is they primarily occurred in the first year of the trial. If you made it beyond the first year of the trial, you're much less likely to present again with a bleed in the future. So, short strokes. This strategy in folks who had peripheral arterial disease and coronary disease markedly decreased the risk of stroke, markedly decreased the risk of event. There was a decrease in all-cause mortality. There was a balance of a 70% increase in major bleeding, but not intracranial bleeding, not life-threatening bleeding. How does that compare to our usual contemporary therapy? If we look at ACE inhibitors, if we look at lipid lowering, do antiplatelet therapy, blood pressure lowering, which we know is quite nicely in terms of relative risk reduction. The benefit here is very consistent with what we'd expect from any of our contemporary therapies. The reality here, and what I want you to just think about a little bit when you're thinking about who you might use this in, is that although the relative risk reductions line up, you don't see the absolute risk reductions in this trial, or in this table. The absolute risk reduction of about 1.3%. That's not zero. But you need to treat about 70 to 80 patients with straightforward disease before there's going to be a benefit. So that's significant. If you're using ACE inhibitor in the whole population, you need to treat about 30 patients. So that's significantly different. Now, to be fair, the whole population is today. We're much more aggressive in terms of therapy. Why does this matter? It matters because there's a group of patients who I think, will clearly benefit from a COMPASS trial regimen, and those are the highest risk patients. The patients who presented with peripheral arterial disease, who had an intervention, or who have what we're now calling polyvascular disease. And you'll see this in your patients, and this is what typically I wouldn't necessarily screen for peripheral arterial disease, but now I'm starting to do so, because it's becoming increasingly clear from this trial and several trials like it, that if you have polyvascular disease, if you presented with an event, if you just have peripheral arterial disease alone that's been symptomatic, your risk of having a bad outcome is very high. And it's my thinking that it's this group of patients that we should be focusing on the regimen. If you think about the patients who got into the trial, they say coronary disease, but they don't mean a 70% distal RCA lesion back in 2001. It means at least two vascular territories involved. Moreover, you had to be at least greater than 65, or you had to have another vascular event involved, or you had to have another 2 risk factors that really is going to benefit markedly from this regimen. It's folks who have either polyvascular disease or have had an event. They're the ones whose relative risk is going to be decreased the most because their absolute risk is that much higher. So when you hear about using this regimen, and you'll see us using it, just bear that in mind, that if you're going to select a patient that's going to benefit, it's the highest risk patients. You're not going to use it, or you're not going to want to use it, and those folks are at high risk for bleeding. Any questions about that? It's a very quick run through COMPASS. Yeah.
We're not talking about the people with some carotid interval thickening.
No,
you're talking
no.
We're with limb extremity, right?
I apologize. We're absolutely talking about folks who have advanced, and in many cases, polyvascular. So you'll be seeing this again. You're going to hear about it again. There'll be more talks about it again. This is a very brief overview of Compass with a few thoughts. Yeah.
Mike, what about aspirin?
Yeah.
Was the aspirin significantly better than rivaroxaban alone in Compass?
In which arm? So there's 3 arms. There's the aspirin arm. The Compass had the rivaroxaban 5 alone twice a day, and 2.5 with aspirin. So in each rivaroxaban arm, there's superiority compared to aspirin. The rivaroxaban 2.5 and aspirin was superior to rivaroxaban 5 alone.
Either one.
Yeah, which was itself superior to aspirin. So it was the combination of the two and the low dosing that seemed to provide benefit to patients.
So the whole thing is, the peripheral vasculitis is a systemic disease, right?
Yeah.
They've only trying to establish that they have interest, like they go after the coronary arteries or they go after the carotid arteries. It's not that simple to diagnose or whole generalize what's happening in the vascular system. If you really see some of the people that have borderline cholesterol, they have a very strong history of coronary artery disease. You investigate over and over to them, they ended up in years having a heart attack. So I think it's beyond the hyperlipidemia. There are some other factors, microscopic changes or genetic predisposition, vascular changes. Why we don't focus on those one? Those are the underlying pathology. Then of course this is very important to prevent the primary prevention, but we're not really, the secondary prevention probably, but we're not going to real basic primary prevention. Is there anybody did any research to see where we're going in that area?
So in the interest of time, and to move on to our speaker of the evening, we'll take that offline, and you and I can chat afterwards, because there's a ton of work up there. Is there anything else that's sort of a burning platform question here that we absolutely must need the answer? Otherwise, I want to take an opportunity to introduce. Yeah.
Can you get Mike's video back on?
Yeah.
He does an intro production.
Yeah.
Thank you. So I told you I would walk away, and I did. I can't help myself. So Dr. Sheldon Tobe, who we were just talking just before the talk, I have known since the 1990s, since his children were young, playing pee-wee hockey, who are now 30 and your grandfather. So, wow. That doesn't make you old, that makes me old. And I don't like that. Sheldon is a professor of medicine at the University of Toronto. He's a nephrologist practicing at Sunnybrook Health Sciences Center. Has a particular interest in hypertension and clinical research. Really primarily focused on hypertension, was the chair of the CHEP guidelines for 5 years up until 2012. Still sits on the board, I think, of the CHEP guidelines. Is now particularly interested in the Sea Change program, which is a program really focused on trying to bring together disparate recommendations, make sense of them, so that when they're sent out to us, we can know where to turn. So it's an important program. It's good work. I'm very happy to have you here. He is an excellent speaker. He's a fantastic clinician. He was a great mentor. So, Sheldon, we'll turn it over to you.
Thanks, Mike. Yeah, it's awesome to be introduced by former trainee. And Mike was an absolute all-star at Sunnybrook. And it's great to see your career being so successful. And thank you very much for the kind words. Tonight I'm going to talk about something that I don't often get a chance to talk about, which is a lot of fun for me. And it's a bit about guidelines development, and particularly, it's the kind of thing that I love to talk about. Like, you'll hear Mike talking about coronary arteries and various studies of lowering risk. I hope I won't get too carried away talking about some of the more arcane aspects of guidelines development. If I do, just stick up your hands and tell me to move along. I think that it's great to see the agenda coming up for your talks for this part of the year. And I think it's a great way to start, because most of your talks are going to be guidelines related. Sometimes they're going to be ahead of the guidelines, like COMPASS. COMPASS is going to be incorporated into the CCS guidelines for management of patients with coronary artery disease. I'm not sure how. This is what drives our next coming guidelines. So it's just to put things into context. You're seeing that new data. I'm not sure exactly how we're going to incorporate it into practice. In Peterborough, you tend to be on the leading edge, and often the guidelines just follow right on behind you. And we're likely to see that with COMPASS. So watch out this fall for new guidelines to incorporate the COMPASS information. So I'm going to talk a bit about that process. They talk about sausages, and sausages are yummy. I love them, but you don't want to go to the sausage factory. I'm going to tell you some tales about the sausage factory.
So spacebar issue.
Spacebar is the way we go to the next slide. Now I should have on my next slide. Sorry, Don, it's not. I should have on my next slide my conflicts, and still have.
So let's just do it with.
I can do it with the mouse.
Yeah.
Cool. I should have my conflicts that I'm still a national chair for a diabetic nephropathy study with finerenone. That's the Bayer study. We just finished the SONAR study with AbbVie. Those are my main conflicts out for April 12th, or is it April 15th, where the Credence and the SONAR study will be announced in Melbourne, Australia, the International Society of Nephrology. We're going to change, just like COMPASS, we're going to change clinical practice guidelines again. So keep your eyes open for that. Tonight we're going to talk about, here's what happens when you get old. The rationale, process, and goals of outline the strategies for dissemination, and provide some tips for adoption and implementation in primary care. So I'm going to use 3 examples: blood pressure treatment thresholds and targets. We'll talk a little bit about cardiovascular protection in patients with diabetes, and new heart failure recommendations. And I'm hoping to set up the talks that are going to come subsequent weeks. First of all, guidelines. They're not meant to bind you. They are not meant to take away your autonomy. They are meant to open up your practice and make it easier to practice and to free you. They're not handcuffs. Handcuffs are policy. They are things like hand washing. For those online. When I'm making dialysis rounds, Elliot, I don't know if you have the same thing. So we go from station to station. Sometimes I just say hello to the patient. They're fine. I don't touch the chart. I don't touch the patient. We just have an exchange of information. But God forbid I don't pump spray my hands in between patients, and the clipboard nurse is watching me. Okay, I'm publicly shamed in front of the entire institution, and our whole division is made to look awful. So I'm a exemplar. If I had my badge here, you'd see all sorts of gold stars on it for good behavior. My skin is worn raw from doing that. That's a must do. Our guidelines are should do's and should not do. That means that they're what most people would do if they understood like we do about the implications of that information. There's should do's and should not do's. And they're signposts. So they may or may not apply to your patient. Let's say we're talking about blood pressure lower. You have a patient you know has carotid artery disease. And if you lower their blood pressure, say they're a sprint patient, you want to do intensified blood pressure lowering according to the guidelines, targeting a systole of less than 120, and you target that lower blood pressure, you know that you're not going to perfuse that patient's brain and they're going to fall over and break their hip. Not a good thing. All we expect you to do is to be able to tell the patient, Tobe says your recommendation for blood pressure should be, that's what our clinical practice guideline says, but Because of your carotid artery disease, we can't get there. Therefore, we're going to target a blood pressure of around 140, which is going to work well for you and keep you out of trouble. And to be able to explain to the patient why they do or do not match that particular clinical practice guideline. That's the expectation. So guidelines are there to help us practice across an entire population. They make sense and they improve the care of patients. They improve outcomes. But for your individual patient, you know them the best. You decide what's appropriate for your patient. Similarly, our guidelines help us work together with the interprofessional team. How many of you are fortunate enough to work with an interprofessional team? Docs, virtually everybody here. So it's really fortunate, and it makes our practice a lot better, particularly, as we were talking about earlier, with our more intense patients. Our patients who have multiple comorbidities, need to be on multiple medications, and it's so helpful to have a pharmacist and a nurse practitioner, social worker, dietitian, whoever's part of that team to help us manage these ever more. And if we're all following the same clinical practice guidelines, we're all singing from the same song sheet. It makes our management a lot easier. So I'm going to tell you some good news. This is data that comes from the old ICES, now the Institute of Clinical Evaluative Sciences. ICES is the new term. That's not the bad ISIS. And Jack, too, passed away last year very suddenly and unexpectedly. Helped to lead data, and it comes from his CanHeart project. And we're looking at outcomes on the x-axis over about a decade, 2004 up to 2014. And on the y-axis are various rates of these bad outcomes. And you can see the bad outcomes in the boxes, and you can notice falling. The rates of all these bad cardiovascular outcomes are falling. And that's because of the excellent care that you are all providing to your patients. It's quite remarkable, and I've put here some examples on. Most notably, reductions of hospitalization rate for unstable angina by over 80% and TIA by over 60%. These are huge changes. Mike, sure you remember back in the 1990s, unstable angina was something you saw emerge on a regular basis. Right now it's like, ooh, I saw a patient with unstable angina. It's not all that common anymore like it was. So huge improvements in outcomes. Contributing factors, improvement in cholesterol management, blood pressure control. Canada leads the world in blood pressure control. Of course, we can do better, talk about that. And advances in management of heart failure, stroke, cardiovascular management, just as Mike described, exciting improvements. And that relative risk reduction, although small, is on top of statin inhibition, aspirin, and so on. So we continue to improve slowly, and each subsequent improvement becomes less, but still is highly meaningful. However, because of rising rates of diabetes and obesity in the youth, in the younger generation, after they finish playing hockey and they settle down with girlfriends and children, they get obese. Sedentary. There's now an uncomfortable spike in younger people, and I'm sure you're starting to see this, where these young folks are coming in and they're having more cardiovascular events. There you go. All of those risk factors that we reduce inflammation. And by reducing inflammation, we're really helping to prevent disease. So all of these things that we do together, a multi-comorbid reduction helps to improve our patients. And you can look at those inflammatory markers, and those inflammatory markers really come down. And Cardiovascular Network in Peterborough has really led the way in maybe 1 or 2 standard deviations ahead, catching up and learning what you're doing. So in terms of tremendous advancements in screening, prevention, and treatment of atherosclerotic cardiovascular disease, and it's had a huge impact on public health. we were talking just before the talk about the fact that despite an increased number of people aging and getting over age 65, now 1,000 clicking over age 65, not too many years old, I'll be one of those, and a shrinkage of the number of acute care beds, our system remains intact. And it's because of excellent care like this. So we have to continue to be vigilant and continue to innovate to improve our care. However, of Canadians have suboptimal health, and particularly 90% of Canadians have one cardiovascular risk factor that's not being managed. Typically, it's LDL cholesterol. It could be diabetes. We did a screen at Sunnybrook for a research study not too long ago. Hospital employees were the predominant people coming out for the screening, had diabetes and didn't know it. Those are people who work in the healthcare institute, and yet they didn't know they had diabetes. So you see it all the time in primary care. This is underlying huge well of people with comorbidities, cardiovascular risk, and access to the healthcare system really is not to be found. We have to actively go out and find these folks. So what is C-Change? C-Change is the guidelines group you never heard of. The reason you haven't heard of it is that there's very little money behind C-Change. C-Change has no drug company funds, therefore it has no funds. So it's a pretty lean organization. The CIHR and the Public Health Agency, when they're generous enough to give some kind of ebb and flow over time. And we just published our third set of clinical practice guidelines. That came out in the Canadian Medical Association Journal back in October. So I hope you have that. You can download it. Email me at sheldon.tobe@sunnybrook.ca. If you're interested, C-Change is nationally endorsed by the Canadian Medical Association and Nurses Association, and it's an umbrella group that brings together the guidelines from 9 of Canada's major cardiovascular-focused clinical practice guidelines. Because C-Change doesn't get any funds from the drug industry, it's acceptable government. It's acceptable at medical schools. You'd be surprised that most medical schools in this country teach clinical practice guidelines from other countries. Because they say, oh, we can't possibly teach the Canadian hypertension guidelines because that organization is associated with the drug industry. So we'll teach the American ones because they don't know what it's associated with. Seems like they don't know it must be okay. That kind of thing makes me crazy. But you can argue about all the checks and balances with each of the groups, like Diabetes Canada and so on. But yet C-Change is acceptable. And what C-Change does is chooses a select number of recommendations from each of those other guidelines groups to put together a limited subset of guidelines of recommendations to the care community. All volunteer driven, because we don't have money to hire people, and it's and I'll explain some of the benefits that come back and forth, that flow back and forth for those groups. But first, implementation science. How do we get this information that's collected from these clinical studies, like COMPASS, and then turn that into, COMPASS comes out, let's just use that as an example. The myocardial leads in Canada, look at the study, understand it, change their clinical practice. But as a nephrologist, I don't hear about that. As primary care clinicians, you may not hear about it either, unless you attend rounds that are given by Mike and other cardiologists. Start changing your practice, then you tell me, you say, Tobe, how come you're not doing that in your practice? And I learn about it, and that whole process can take 10 years before new information gets around and we all change our practice because of it. The management of microalbuminuria in patients with diabetes was a great example. We had new information that came out in the year 2000 of patients with diabetes. Using RAS blockade, they give renal protection over and above blood pressure control. We mounted a big public health campaign. We trained primary care docs across the country. They changed their practice within 2 or 3 years. And then cardiologists started saying, "Oh, what's going on here? How come the primary care docs are all using RAS blockade and albuminuria?" And then cardiologists changed their practice as well. So it's interesting how these things can go. But implementation science is all about moving this faster, moving the train faster, getting it going, getting us all on board, and practicing in a homogeneous way consistently according to the evidence. Also, local context and tailoring. So we'll talk about, this is a big country, it's diverse. And populations are not the same in each area. So it stands to reason that we should adjust our clinical practice guidelines for the needs of each region. And so it's important when we're developing clinical practice guidelines that we allow the development of implementation tools of each region. And so the goal of C-Change, the process is for all Canadian healthcare providers to have easy access to a comprehensive and usable set of harmonized guidelines. That is so cool. I'm going to use this pencil. I love this technology. So what's the scope care? And it's directed at adult Canadians who are at risk for cardiovascular disease. 7 million Canadians with hypertension, 400,000 new hypertensives every year in the country. Patients who have diabetes, as I mentioned, there's a whole ton of people with diabetes out there who don't know they have it. Dyslipidemia, heart failure, stroke, and the conditions that lead to those conditions, particularly smoking, obesity, and sedentary behavior. We'll talk a bit about sedentary behavior in a few minutes. C-Change is all volunteer, and all the guidelines groups are all based on volunteers. So they're academics with an interest in that particular area, and they help for each cycle of guidelines development to work on the clinical practice. What we do with C-Change is we bring a representative from each of the guidelines groups, Diabetes Canada, Hypertension Canada, to work together, liaise back and forth to make sure that there's good communication. And we also promote quality improvement for the guidelines development. So in Hypertension Canada, we do an excellent job at developing clinical practice guidelines. We can always do a little better, recognized around the world for doing, for having an excellent process. Similarly for Diabetes Canada. Now we have a group of experts, critical appraisal experts, that help us evaluate that evidence. So we have people like myself, part of a subgroup. In fact, we had a meeting just this afternoon for the resistant hypertension group. It's active, and we'll be reporting on new recommendations for managing patients with resistant hypertension. But we all have various conflicts of interest. So we have someone who is part of the Central Review Committee, we call it. It's not a communist organization, that has no conflicts of interest, but is a critical appraisal expert. And there are people like that, and we collect them as they become available. It's great academic currency for them, and then we share them out with the other guidelines groups and help them develop. Then we work together, and we don't, with C-Change, we don't tell the guidelines groups how to do their recommendations, but if they're having trouble with their methodology, we'll help them strengthen that. We also score them. The website, the score is called an Agree To tool. We score each of the guidelines groups, let them know how well they're doing. Do they have a patient representative as part of their group helping to advise them? That's one example. Are they declaring their conflicts of interest? Are they doing their critical appraisal properly? Are they doing their system properly and publishing it and letting us see where it is and what they've done? Then we go through this process, and I won't go through the nitty-gritty, but it's a little bit circular, and it's like chasing a herd of cats in a circle many times. A lot. And then at the end of the day, recommendations, and it works out really well. But I can't believe I did all of that and chased a herd of cats around for 2 years, and it worked again. So it's really very rewarding. The cats all want to get to the end, but they all want to take a different route, do it a different way. Then it's surprising that we can get everybody. Here are the 9 groups. This year we added heart failure to our process, just as an example. You might remember the heart failure group had 800 recommendations in their old guidelines, and that was circa 2008, 2009. And amongst those 800 guidelines, there are recommendations, pressures, and atrial natriuretic peptide, and BNP, and various things. I could not understand what they were. I've been around this area for a while, but the kind of detailed heart failure management talk was just beyond what I could understand. So they said they were interested in participating in Sea Change. So I said, yeah, we had a chat with them and explained what the process was like. And I said, the first thing they're going to do is slim this down to a quarter the number of recommendations, and they're going to be worded in a way that someone like myself can understand them. No one can, they're not actionable. So they actually did it. They did that work. They hate me because it was a painful process. That's great. Primary care is going to want all 200 recommendations. I said, no. We're going to choose 10 recommendations for primary care. And they were like, oh my God, they didn't talk to me for 3/4 of a year. They're so mad. But they did a great set of recommendations that came out in the Canadian Journal of Cardiology, October of 2017. And you can pick it up on the Canadian Cardiovascular Society website. And then we chose a subset, and I'll show you a couple of them for Sea Change. Anyway, it turned into a great process, and the heart failure guidelines, I believe, are vastly, vastly superior to what they had been. And they're really implementable. That's an example of how we can help the process. Now, around the world, there is no other guide like we do in Canada. The closest that there is the NICE group in the UK. Oh, they have just such a great group. They do all the things that I've described, plus they bring the stakeholders in, but it's all government funded. And the budget would fund a small city and keep it running. They fund meetings. Government is involved, and there's a bit of a heavy hand of government on the recommendations. You can feel that flavor. We don't have that in this country, and we run it pretty much all through volunteer work. So I think we get a better product in the end. And why is it important? Well, if you have a patient up to hypertension recommendations and hypertension guidelines, and look for the particular guideline that fits that patient. But how many patients do you have that only have hypertension, or only have diabetes, or only have dyslipidemia? Right? There's not many. Most of our patients have multiple comorbidities. And for those with hypertension, 90%. So when you want to manage multiple comorbidities together, it's really helpful to have guidelines that take that into account. So you don't have to look in multiple places. So to summarize, Sea Change promotes patient care by bringing these 9 guidelines groups together. Our 2018 update for the Sea Change harmonized cardiovascular guidelines have 77 recommended number and 52 that that are brand new or updated. We added heart failure, and an example of a new category for hypertension is the SPRINT recommendation. And we'll talk a bit about that. So someone who's higher cardiovascular risk, say age 75 and above, systolic blood pressure over 130 are target, and multifaceted care for patients with cardiovascular risks. And when we do all of that, wait an hour. We're going to reduce inflammation. In this country, there are lots of regional attempts to create new clinical practice guidelines. And I like the fact guidelines, and sometimes a hospital will take it on, or a LIN, or a province. Often don't look to the national guidelines group to harmonize with them. They do things on their own, and they end up with discrepancies. I'll give you an example. In Ontario, the Ontario Renal Network says that someone has albuminuria if their albumin to creatinine ratio is 3 or greater. And that comes from international recommendations, and worldwide, that's the sort of accepted number. However, Diabetes Canada says abnormal albuminuria is an albumin to creatinine ratio of 2 or greater. So you may see some differences. And when you see those differences, that's confusing. And when we get confused, we don't practice consistently. So I know that particular one because I set out specifically this cycle to eliminate that discrepancy, and I failed. So I don't know if I'll still be around in the guidelines world to work on that for you, and hopefully we'll get that discrepancy ironed out. But those kind of confusion lead to lack of homogeneity and so on. And that's where you get this ownership aspect of these clinical domains. I own 2, I own 3. Well, who cares? 2 or 3 doesn't really matter. We want to get our patients treated, our higher risk patients treated and controlled. And whichever one we choose. Another example is walking. Wow, a big lesson in 2018. All of us are quite comfortable recommending to patients to walk 150 minutes a week in brisk walking, moderate level of activity, and do that in 30-minute bouts 5 days a week. How many of you counsel your patients about doing that walks? Okay, it's not so simple. And I have helped create a problem through Sea Change and through the guidelines groups with that. I couldn't figure out why the kinesiologists were pissed every time we talked about that recommendation. Here's the reason. With high inactivity rates, there's challenges. What about our patients who are disabled, had hips, they can't walk? When I tell my mom, age 83, Mom, you got to walk 150 minutes a week briskly to get in all the work that you need to get your exercise, to keep your blood pressure down, and so on. She nods politely at me, and then she says, you know what, you're such an idiot. I can't do that, too. And I just nod politely and say, yes, doctor. But for those folks, they can't do it. So what are we supposed to do when we just recommend this moderate activity walking? The answer is, and I've just discovered what the answer is that for patients who have low intensity ability, they need to do the activity longer. Right? They need to do the activity longer. They're going to do it slower, but they do it longer. So we're actually the first group to figure out, and this is the one where we started with golf. My son is a golf pro, so he helped me translate the numbers that the kinesiologists had created into actual numbers. So for Mom, who can't walk briskly 150 minutes a week, all she has to do is rounds of golf 9 holes a week. And that translates to enough minutes. Oh, and those rounds of golf that she's going to play, she's not carrying her clubs. She's taking the cart and walking perpendicular from the cart path to the ball. 3 rounds of 9 a week. That is the equivalent for someone who can do moderate exercise of the 150 minutes a week. For someone of high intensity, Mike or Elliot, young guys who are really still at their peak, that's carrying the bag and running the course, doing it in 2 hours. Maybe. You guys are laughing. You're not going to. Okay. Well, in years gone by. right? Yeah. That was feasible. And it turns out that all of the different guidelines groups have a different way of approaching the walking. So this is how we help them work together to do that. The other thing they were mad about that we hadn't included, that is now included, is that the greatest benefit for improving activity comes from going from sedentary to doing anything. So when we tell a patient who's sedentary 50 minutes a week, they say, yes, doctor, that's a great idea. Maybe tomorrow or some other take that on. And if they don't walk, they're not going to get that benefit. But if they go from sedentary to doing anything, they're halfway there. They get half of the benefit just from standing up and doing anything. So if we can get them out to the course to play around, or if we get them out to the course just to swing their the practice range, that's a huge benefit for those patients. So that's the kind of thing we can help the guidelines groups with sea change. Best practice for guideline harmonization. There's a whole table. I won't take you through all the nitty-gritty, but we have to making sure that the guidelines development is as best as possible. And that also means not having the heavy hand of government interfering with it either. Watch for a paper coming out in CJC, Canadian Journal of Cardiology, describing that. Okay. Questions about guidelines development, efforts, dissemination.
In Toronto, how many would there be in your group that gets together to discuss teaching? Like, is every teaching hospital contributing members to the group, or is this?
So the question is, in Toronto, how many people get together to discuss sea change and so on? Well, in Toronto, I think we have 4 members. And right across the country, there are about 30 members. But it's hard to bring us all together when we don't have funding. So we take advantage of various meetings, do lots of teleconferencing and video conferencing. Having links in each of the centers to do dissemination is challenging. And we're trying to establish those links. So being invited is exciting for me because this is the kind of thing I'm hoping to see. Rahul Jain, Family Doc at Sunnybrook, is putting together an education module on sea change, and you'll see that on the website. How many CCFP members? Here, lots. If you go to your website, CCFP, and look for Prevention in Hand, so if you Google CCFP and PIA, go to your website, to CCFP website, Prevention in Hand, click the little blue link, and you'll see some of our online modules that are there. That's our first shot at it, and we're going to have a new version of those that'll be a little more user-friendly coming up soon. Other questions?
I'm just wondering if the point of this is the application of these guidelines to patients, but where you're supposed to do this in a transparent manner and in concert with the patient. In order for me to deliver that, I really need to have some limited awareness of the evidence base. So, for instance, your example up there, the SGLT2 inhibitor, is now supposed to be, that would be in the guidelines. I wonder if the guidelines told me so that I could be transparent and a team player, that the relative risk is, for that particular example, would be 35%. The absolute risk would be about 2.5%. I think that's the kind of information that I need in the guideline so that I can share in a transparent manner with the patient.
So it's there now in our guideline, that particular recommendation, there's a little discussion about it, and each of the recommendations in sea change is referenced, so you can follow that reference back to the original manuscript. Now, if I was really good, that would be on our website. So you could just go to the website, click, and it would be there. But what to do is what I would like to do, and we will do eventual source. And I could approach Big Pharma, and they would do it in a heartbeat. But as soon as we do that, we're tainted, and we lose all our credibility. So we limp along slowly developing these things over time. So what we need to do now, without a nice tool that gives you that quickly, is you have to follow our links to the references and check it out yourself.
Which is the reason that I wouldn't then use the guideline.
Understood. So we're working on an app that will just be linking to our website that will make that a little bit easier. It just takes time. When you're working with a volunteer organization, you know there's only so much time that everybody has to do that. But if you're keen to help, we are always volunteers. Please let me know. Email me.
Government funding if it was available, or would that?
Oh, yeah. Oh, yeah, we take government funding in a heartbeat.
Or why?
Our government will not fund guidelines development. They've made it very clear. But implementation, yes, but it's hard to get. We're making another stab at that. Working with the Ontario College of Art and Design University, so we now have a design process for developing our tools. I always say, oh yeah, we'll do whatever, we'll put that information that you're looking for on a laminated piece of cardboard that goes in our pocket. You should see the design folks at OCADU when I say that. They go, oh my God, it's like I'm scratching nails on a board. But their process is amazing. So we have a process in place to do that. It just takes time. So not to take away from Subodh Verma's talk, but I want to set you up to put his talk into context. We have a new practice recommendation for patients with diabetes to reduce cardiovascular risk. So how do we disseminate this? Patients who have diabetes and higher cardiovascular risk should be treated with an SGLT2 inhibitor or a GLP-1 agonist. This is a new recommendation. So when I look at my own, lots of patients with type 2 diabetes, my practice, like Elliot's practice, they virtually all have higher cardiovascular risk. They should be on these agents if their renal function, in our case, is high enough. But in primary care, they should all be treated. So how do we disseminate that? We've actually got a module to do that. It will be super helpful. And these agents are really something. So here, this is one of our practice modules that we have, and it's on our website. And I didn't show, sorry, Don, I didn't show our website at the beginning, but if you're interested in going to the C-Change website, it's not that hard. It's cchangeguidelines.com. CCHANGE guidelines.com. And it's a pretty rudimentary website, but all the information's there. And you can see the module for cardiovascular risk reduction. So we'll just go through some of these. The one that is incorrect here is bone health. Oh, these agents don't improve bone health, but they don't make it worse. SGLT2 inhibitors, and in the clinical studies, we see more fractures from people falling over from hypotension. But for all the other factors, they are improving health. So do they lower blood sugar? Yeah, sure, they lower blood sugar. And of interest, the higher the A1C, the bigger the bang for the buck you get when you add these agents. They lower blood pressure. I think of these new agents as antihypertensives that also lower blood sugar. Super cool. They're very effective at lowering blood pressure, particularly in patients on multiple agents who have volume problems. And they consistently give a nice reduction of blood pressure. Weight loss, for sure, particularly the GLP-1 agonists. We just finished this called Rewind that will be coming out soon with dulaglutide. That's Trulicity. And I've never had a study before where we've recruited patients. One of my patients, his wife is a family doc, and she came in and said, I want to be in your study because I want to be on the drug that my husband's on. Wow, there's something going on in this study, but patients really have a nice dramatic. What about renal outcomes? As I said, stay tuned for March, but the early word is that these agents, both agents, SGLT2 inhibitors in particular, as well as GLP-1 agonists, are renal protective. Reduce albuminuria. Does that turn into a reduction of progressive chronic kidney disease? Stay tuned for April. That answer will, but you know, it's going to be a good answer. Cardiovascular outcomes, absolutely. So we have the EMPA-REG study, and all of the other agents are also showing a nice reduction of cardiovascular outcomes, primarily due to a reduction of heart failure. So when Subodh Verma is here, I want someone to ask him, gee, Subodh, how come there's such a reduction of heart failure factor in the coronary arteries or the heart muscle, or is it just that they're causing sodium loss and improving the volume status of the patients? Like I think it is.
Dysfunction. Diastolic dysfunction is the main cause of this early heart failure.
Patients who have diabetes and hypertension get diastolic dysfunction, and they get it early. Once they have diastolic dysfunction, treatment for it. Our best management of diastolic dysfunction is prevention, preventing it from happening in the first place. Once someone has diastolic dysfunction, diabetes, hypertension, diastolic dysfunction, that's a heart that doesn't want to relax. That patient has a dinner similar to ours. Maybe they go to the Mandarin buffet, pack of sodium, bunch of slices of pizza while they're watching the football game. They go to sleep. They have a little bit of edema, they notice, before they go to bed. They lie down, all that fluid now goes systemically into the intrathoracic space. They get a little laryngeal edema. They have a liter of fluid, their larynx is going to swell up. Now they're getting thick heart, and that thick heart has to be perfused during diastole. And they're already having trouble with relaxation because they have diastolic dysfunction. So those coronaries are perfusing during diastole. So a nice slow heart rate is really helpful for coronary perfusion. I'm not looking at the cardiologist to make sure, because they're making me nervous. And now that patient, their O2 level drops, their heart rate is picking up. When their heart rate picks up, diastole is shortened, coronary perfusion is shortened, their oxygen level is low, they get a stiff ventricle, short of breath, Mike Hartley, pager goes off, he's got to go see that patient. So diastolic dysfunction. When the patient is on an SGLT2 inhibitor, along with that glucose, and it helps to keep them out of trouble, and it helps to break that cycle. That's what I believe is going on. So now you've heard my story, now you can check out with Subodh what he believes, and it will help to put his talk into context. Did I do okay? Cardiologists are... So, lots of data showing that these drugs are cardiovascular protective. I won't steal any more of Subodh's thunder. And that led us to this particular recommendation, the diabetes group, and we're helping to make sure that other groups are saying the same thing. So this recommendation is reflected in sea change, or we'll also include it in Hypertension 2020. I mentioned blood pressure. Our new recommendations include the high-risk patient. This is a patient who is high cardiovascular risk. I'll define it on the next slide. If their systolic blood pressure is 130 or greater, we now target a blood pressure of less than 120. That has this recommendation, and we made this recommendation within a year of the SPRINT study coming out. For diabetes, we're still 130 over 80, and for everybody else, 140 over 90, including patients, not including patients with chronic kidney disease, because they're patients at high risk. So for high-risk patients age 50 or above, with systolic blood pressure levels of or above, cool, intensive management to target a systolic blood pressure of less than 120 should be considered. And we should be guiding our therapy with automated devices. There may be a few of you, I won't ask you to put your hands up, who are still using mercury sphygmomanometers in the office. It's totally fine to use mercury if you're doing a standardized blood pressure measurement, taking about 12 minutes to measure the blood pressure, doing the proper technique for standardized measures. If you don't have that much time in clinic to do the blood pressure, and I don't, then you should be using an automated device. So we should all be using automated devices in the office to measure blood pressure. BP True, no longer available, so now we have to go to other devices like the watch. And who are these patients? Oops, I jumped ahead. These are patients who have clinical or subclinical cardiovascular disease, Framingham risk scores of 15% or above. All of Elliott-Boben's patients with chronic kidney disease, and patients who are age 75 and above. My practice and your practice are now sprint patients. Now we need to target this blood pressure. It's hard to do. It's a journey. It's not necessarily a destination yet, but it's a journey to slowly get our patients' blood pressure under control. And that leads to better cardiovascular outcomes with meaningful numbers needed to treat. In the higher risk groups, we've got, I think it's over 10 years of an NNT of 10. It's pretty dramatic. So yeah, I chased my mom into the family doc to get her blood pressure managed. It was only above 130, so she's on a low dose of antihypertensive. Were there more falls? Yeah, there were more falls. Was there more syncope? Yep, there was more syncope. Was there more hypotension? There was more hypotension, and the intensive was 3 meds versus 2 meds. Were there more injurious falls? No, there were not. In fact, numerically, there were more injurious falls in the group with intensively lowered blood pressure. That's why we have to do these clinical trials. It was remarkably well tolerated. But it's not easy. You have to see the patients more frequently. They need more blood tests. There's more hypokalemia, What's the silver lining for this kind of recommendation and for studies like COMPASS and so on? We will always have work to do. No one, and it's complex. We cannot be replaced by an app, at least not yet. I don't know if anybody could develop an artificial intelligence tool that would accommodate because it's complex. You need a human brain to decide and interact with the patient. So we're not going to be replaced by an app anytime soon. That's my silver lining for you, but it's lots more work. What's happening south of the border? Well, they changed their recommendations based on sprint. They were moving in the other direction for a while. They were talking about systolic blood pressure of 150 in patients with diabetes should be 140 over 90. They changed around. Here's the new categories of blood pressure. Looks okay, but look, normal is now less than 120 over 80. Elevated, 120 to 129. This is south of the border. Stage 1 is what we would call high normal blood pressure. And stage 2 hypertension is what we would call stage 1 hypertension. Now, one thing they did in the US patient guidelines is they set 130 over 80 as the threshold and the target for everybody. And it's not exactly according to the evidence, but it's brilliant in its simplicity. I wish we had the guts to do that, but it's a real experiment. Now, when you do this sort of thing, look what happens to your population. I just want you to focus. It's so cool. And here, I love this. Before the Americans brought out their new sprint recommendations, 1/3 of the adult population had hypertension. Post hypertension recommendations, post November 2017, it's now over 1 year, 46% of the, now they might be right, but that is a massive public health change. Tens of millions of people are now hypertensive that weren't hypertensive just a year ago. Is it going to make a difference? I think it's going to, but we have to see. It's a very, very shocking change. Almost done. So, heart failure recommendations, and I put them here. You can read through them. I'll just go over the last one. And I think they're pretty well written, and I think they're actionable. And they're so much better than they were. And I really pulled hard to get this one in because these agents are called ARNIs. I think that's a really cool acronym for an agent. We've also included them in our hypertension recommendations because they also lower blood pressure. So an ARNI is an angiotensin receptor neprilysin inhibitor. So it's an angiotensin receptor blocker, valsartan, not the bad valsartan from China, but the good valsartan. With a neprilysin inhibitor, that means it increases BNP and ANP. I spent my fellowship studying those compounds, so it's like a diuretic together with an ARB. The diuretic works differently from most diuretics. It does not cause electrolyte disturbance, and it improves hemodynamics. So for patients who have heart failure, we recommend that an ARNI be used in place of an ACE inhibitor or ARB, because it has the ARB in it, in patients who remain symptomatic despite treatment with appropriate doses of goal-determined medical therapy to decrease cardiovascular death, heart failure hospitalizations, and symptoms. So we should all be using ARNIs in our symptomatic heart failure patients. New recommendation, and I think it's quite actionable. And most primary care fraction heart failure patients in your practice, correct? Some yes, some no. It is a combination. Yeah, there's two agents together, valsartan and the neprilysin inhibitor.
Can you give us an example? Is that like Entresto?
That is Entresto. Yes, thank you. That is Entresto.
And the name for that valsartan is?
Sacubitril. Cardiologist, any comment?
Yeah, I absolutely agree, but it's a big deal to transition all those people.
It's a journey.
We're in the process of going through our own practice in that, and it adds 2 or 3 visits by the time you get people optimized.
Not covered.
Not covered.
Under 65, you don't have drug coverage for it.
Well, yeah, sure, that's another issue. Sheldon, so people think you're just the
thank
issue
you.
of coverage
Yeah, for those online, coverage of Entresto for patients age 65 and above, it's there with the limited use. But for under 65, now I had a young patient, and we were able to somehow, I can't remember how we did it, but we must have got compassionate use for that young woman. But how do you implement? This is a challenge, and again, it's a journey. Identify the patient. Are they symptomatic? Consider starting them on Entresto, and it's the only one in class so far.
Your end goal, was that how you're measuring the improvement? I didn't, the outcome is?
The outcome is less hospital admission with heart failure and less cardiovascular death. But really, you're going to see the patients feeling better.
Yeah, many patients feel a lot better.
If you're online, our cardiologists say that I'm absolutely right. Nephrologist practicing cardiology. Let's move on. I'm on thin ice. So, this evening I set out to describe the rationale, process, and goals of guidelines harmonization, and to outline the strategies for dissemination, and to make it somewhat interesting. You know, it's something that excited. Also to talk about some tips for an implementation in primary care, using some examples, blood pressure treatment thresholds and targets around SPRINT, the new cardiovascular protection in diabetes comes from a whole series of studies like EMPA-REG, LEADER, and so on, for reducing cardiovascular risk in our patients with diabetes, not just lowering blood sugar. Heart failure recommendation, we could call it an Entresto recommendation. That's what I should really call it. So we'll stop there, and thank you very much, and see if there's any questions.
Let's join you for a second. Don, could you just check and see if there's any questions?
Yes. Yeah. In the bottom left corner of your screen, there's a chat section where you're able to type in a question or a message to us and hit send. Are there any questions from anybody out there on the web? Thanks.
So Sheldon, I just want, thanks for the great presentation. When you're saying you're sticking your nose in the cardiology world, I think cardiologists feel that they're sticking the nose in the GP world when we suggest SGLT2 inhibition. And so it's, if you get a recommendation from us, who we're looking after some other aspect of your patient, and we taught to manage diabetes. And the way we think about it is that these drugs are actually vascular protective drugs. They're like statins, they're like ACE inhibitors. They happen to help you manage the patient's diabetes. But from our perspective, that's why we're interested in them. But I'm interested to know, to people, how do you feel when you see those kind of recommendations? Do you feel like we're overstepping? Are you comfortable with that? What?
Yeah, it's a right decision.
Buddy offended?
No.
Okay, nobody's offended.
No one's offended.
Nobody's offended in this room.
That's not the right
Everybody's
question, Bill. How do you feel about the cardiologist making a recommendation and not starting the drug themselves?
Well, there's that.
There is that. And that's an important question because it takes a lot of work to manage these drugs.
It does. An SGLT2 inhibitor, I have to talk to my patients about 5 things. Blood sugar lowering, blood pressure lowering, maybe you're going to get hypovolemic. I talk to them about the risk of balanitis and urinary tract infections. Have they had an amputation before? If they have had an amputation, then I would stay away from it. And
Fluids.
blood sugar lowering. Get sick, of course, they could get that. So there's a whole discussion with those patients that is going to take time, and it's hard to do. We all have to be part of that team.
Sheldon, are you able to read the question that's popped up down there?
A question has come up, and it says, orthocardiology, any questions from, okay, Peggy, how do you treat a patient with, aha. Well, diastolic hypertension is a systolic that's normal, and the diastolic is elevated. So you typically see this in younger patients who have a more dynamic hypertension. 1 in 10 hypertensives has isolated diastolic hypertension. So typically, 40-year-old man, his family history of hypertension, now the diastolic is 94. It's too high, you can't ignore that. Systolic is normal. Do you treat that patient? So start with lifestyle and so on. So you've done lifestyle, 3 to 6 months has passed, the diastolic is still elevated. If there's evidence of target organ damage, it really pushes us to treat that patient. I recommend getting an echo in that patient, doing a urine albumin to creatinine ratio. If you see any sign of target organ damage, LVH, concentric remodeling, or an abnormal albumin to creatinine ratio, get them on therapy right away. All antihypertensive therapy works well for these folks. You can use any agent that's appropriate for that patient. Young active male who's going to go out and run and play soccer and run up and down hills and sweat and forget to take a drink all day, you may want to avoid an ACE inhibitor or ARB in that patient and start with a calcium channel blocker like amlodipine. Bring the blood pressure down. And there's no particular agent that is going to drop that diastolic well, and you may not get the diastolic down too far, but once you've seen, get them treated, and then you can repeat the echo 6 months or a year later to see if you've progression.
Well, why would you want to wait till they have a target organ failure? Because you know diastolic dysfunction is not going to be curable. And first thing they start to tell you is the short of breath rather than coming with a high diastolic dysfunction.
Right. So why wait until they get some? We absolutely want to prevent the development of diastolic dysfunction. Absolutely, we want to lower that blood pressure to prevent it, but the patient needs to be on board. Let's say they're a 35-year-old male or a 35-year-old female, really low risk. It's hard to argue that we're going to impact on their cardiovascular outcome measurably in the next 10 years, but we all know what's coming if we don't do treatment board. So we may need to be patient if they're not willing to start therapy right away. We need to give them the benefit of the doubt to try their lifestyle, their lifestyle change, their health behaviors change. Get out on that golf course, carry the bag, sprint around the course, and not lose them, not lose track of them, but follow them and then jump on them as soon as we can. And for sure, as soon as they start showing signs that are leading towards that dysfunction.
Hardy?
What about the other end of the spectrum, the 90-year-old with systolic hypertension, with the systolic of, say, 170 over 80? How are you going to manage that one?
So we want to lower, what about an older patient with isolated systolic height pressure is 180 over 80. So we know that lowering the blood pressure is super helpful in those patients from all those studies of isolated systolic hypertension, like the systolic hypertension in the elderly program. Drop the systolic by 20%, you reduce the cardiovascular outcomes by 40%. But there's a caveat. We want to keep the diastolic above 60. For patients who have coronary artery systolic hypertension, patients do, because they all have rigid pipes. We want to keep their coronary pressure high enough to fill during diastole. And Simon Rabkin showed that when you drop the diastolic pressure in these CAD patients below a diastolic of 60, coronary perfusion really drops off. Again, I'm on thin ice with cardiology. But they're all nodding. So we say drop the systolic, but keep the diastolic above 60. I have a whole bunch of patients whose systolic is 140 to 160. The diastolic is right on 60 or 58, that sort of thing. And I say, that's all. That's all we can lower the blood pressure. We don't want it to come down anymore. Maybe with aggressive vascular treatment, statins, just blood sugar control. After a couple of years, the patient's still around, you might have a narrowing of the pulse pressure, and we might be able to get the systolic down a little more.
Any other questions for Dr. Tobe?
I have kind of a question that's not totally cardiology.
The whole world is totally cardiology.
So, diet guidelines, change sounds like a neat organization. Is there an arm of your group that works with like depression guidelines or mental health guidelines or other family practice issue guidelines?
So the question is, could C-Change be expanded to include other chronic disease management groups? And we would dearly love to. So we've reached out to the COPD group for asthma, to the arthritis group for osteoarthritis. We've reached out that, there's no actual national mental health group that does national mental health guidelines. So we're trying to figure out who are the right players. But if we bring all those groups together, we've hit all the chronic diseases. And that's our goal. And before our next cycle, to 2023, I hope to have all those groups on board. We almost contribute a paragraph in our last set of recommendations, but the Canadian Medical Association Journal threw my paragraph out, said we were over the limit, and that wasn't part of the current cycle. So yeah, we are working towards that. And thank you for that de novo suggestion, because that really tells me we're on the right pathway.
I was going to ask you about this beg for your information.
The CMAJ. Well,
maybe that's not a...
So I'm live and getting recorded. So they're a wonderful organization to work with. And Dan Kiesel, they're really helpful. We have a little podcast that's part of the thing, kids. And at 7:02, that I want to trip. They're really good, and they love our guidelines because they're the most cited. Guidelines articles are the most cited articles, so they're very happy to have it. And they're a lot of work, but at the end of the day, you end up with a much better product. A lot fewer hairs, but a much.
Okay, one more question.
Quick question. Direct renin inhibitors, that was the best drug invented. They stopped using it. That was the strongest antihypertensive drug I found in the especially elderly population. The second thing, how do you manage hypertension crisis if you think the patient is in the office? Should they admit him in the hospital or bring him back again tomorrow and see next day?
Sure. So I'll answer quickly so we can get to that second question. Direct renin inhibitors were great drugs, not the most potent drugs for sure, but really awesome drugs. Novartis totally dropped the ball on direct renin inhibitors. We lost the first drug of a new class. I really hope we see DRIs back again. I won't say anything more about hypertensive crisis. So blood pressure is high. Here we're talking diastolic. Diastolic over 120, and the patient's having symptoms. That's a medical emergency, needs to be managed. I prefer the patient comes in a hospital. I prefer they have an intensive kind of bed. If they refuse, and so many patients in my office, I see them and they refuse to come in. I see them every day, and they pay an arm and a leg in parking. And they come and I treat them and I adjust their therapy and I beg them to go in and I make them sign the AMA form, whatever, but we could manage them that way. But if they're having really bad symptoms, dissecting aneurysms, that sort of thing, they have to come in.
John?
It came out yesterday that the Mexico, $100 million.
Well, one sec. Hold on. So, starting off in Mexico, that the former president of Mexico got paid off $100 million. Okay, so really interesting question. Okay.
And they didn't ask for any notoriety. It was quiet. So I'm wondering if that couldn't be your funding source.
No, one shot, damn the consequences.
We got a couple more questions here.
Okay, there's a couple more.
Well, one more.
One more. Thank you, Christy.
So the Christie's in Halliburton.
I'm interested in about what we know about applying these hypertension guidelines in over 75-year-olds who are frail and are cognitively impaired. Okay, cognitive impairment was a contraindication to getting into sprint. So we would not, individual patient, if it made sense to treat that patient, I would argue no. Cognitively impaired are more likely to fall and get into trouble. But what about frail? That was the boss I hung up on. What about frail patients? Well, I'll tell you an interesting anecdote. So the answer is yes, frail is okay. The interesting anecdote, two interesting anecdotes. One is that in the hypertension guidelines group published after Sprint came out, that frailty was a contraindication for getting into Sprint. That's so it came out in November, January, February, March. They published. In June, the first frailty paper came out. 1/3 of the Sprint patients were frail. 1/3. Oh my God. And then another frailty paper came out to less fit to frail. The absolute improvement in outcome was highest in the frail patients. Oh my God, go figure. So frailty is not a contraindication. And those frail patients, yeah, they have more falls. They have more electrolyte imbalance. But they live longer when you lower their blood pressure. It's really something.
So I'll just put a last call for us to submit a question. We'll just give it another minute or two for there. And any more questions in the room?
Bill, can you give us your thoughts about Big Pharma and the reputation that they have with regard to they altering how we practice medicine? I've been in medicine a long time, and beneficial to helping me learn and know what their opportunities are at every meeting. And I always am angry when I hear Big Pharma being strung out and criticizing us for having anything to do with them. It's kind of a difficult question, but it pops up in my mind. But I don't know what the other people.
Yeah, and I think the problem is that there are several examples. Yeah, sorry, excuse me. So Jim was asking about the role of Big Pharma, and I think this follows upon Sheldon's commentary that the work that they're doing, the very important work that they're doing, is not funded, and so it makes it extra hard to get to the finish line that they're able to do. But when you have the experience of the opioid crisis and the suppression of information by Big Pharma and knowledgeably promoting drugs that were actually more harmful than helpful, I think it's really hard to get beyond that and say that it's a good thing, that we should involve them more. One of the reasons we're doing the program this way is that to the extent that there is pharma contribution link, they're not involved in planning, they're not involved in selecting, they don't get to sponsor a night when their drug is being featured. So it enables us to do some things in sort of a hybrid way where, oh, wait an hour for that, where we do get enabled to get together and learn things without close attachment to pharma that some other events would feature. So an acceptable way to people in the community, and that's where we're going to try and proceed.
Yeah, I agree 100%. But if it wasn't for Big Pharma, we wouldn't have all these great drugs and conducting the clinical studies. But they're to, and we have to be very careful that we keep our patients' priorities as our #1 priority. It used to be in the old days, in the 2000s, man, everything was great. You had these big companies, they were the leaders, and you could do anything you want in terms of continuing education, because if you increase the size of the pie, right, the big ship rises the most when things improve. So you had carte blanche. Today, they want a return on investment. So really everything has changed. Continuing professional development has changed. And the reason I'm saying this is gives me a segue to mention about March 23rd. If you go to our website, we've got a nice education day on March 23rd, Saturday, March 23rd, where we have our modules. Yes, a different approach to providing continuing professional development that is following all the rules of the CPD providers, in this case U of T. And so we do need to work together for implementation projects, but the rules have changed, and we really need to be driving.
Scott?
I guess I do have a last question. It involves prescribing drugs till the end of life, and I know people decline at different rates. Different individuals have that process going on in their lives. Could there be guidelines developed in which we could say you have a score of X on your going to die scale, and at 91 you can stop your statin? Because we're all going to be bankrupt as a society if we keep prescribing every drug to every person until they die.
So can we have so for the folks online, can we have guidelines about withdrawal and de-escalating therapy towards the end of life? I'll give you my thought on that. Prior to 1990, we believed that treating isolated systolic hypertension in the elderly was not a benefit at all. And then what we've learned is that it really was a huge benefit, and analysis from all those studies was huge. We haven't seen the cost benefit around Sprint, but Sprint has expanded that into the frail elderly. Who knew that lowering blood pressure in that group was beneficial? I predict we're going to see that for statins. We just have an analysis out of ICES on intensified statin use is no better than regular statin use in the elderly, no statin use. So some groups are saying, geriatricians in particular, well, we don't have any information above age 80. But boy, I want my mom's LDL down. Cardiologists are telling us they're seeing lots of soft plaque in these folks. So I really think, I certainly encourage treatment. Now, when someone's in a nursing home and they're totally get it, Elliot and I, managing patients on with chronic kidney disease on dialysis, we don't have the evidence for patients on dialysis. The cardiologists tell us to use statins. By all means, we do. And we often de-escalate therapy as patients get towards the end. But we need lots more information. And boy, we're seeing a lot of patients out there in their 90s, the United States, and we want to keep them well and functioning outside of the healthcare system. So I think some core number of medications are really helpful for keeping these folks going. Now, when we talk about biologicals, I really don't know. I think we're really getting onto a different area for the super expensive ones.
If I could just comment on that, one of the questions that Scott raised was, and I think the important part of that is to have the conversation with the patient to say that there is a possibility withdrawing this drug will increase your chance of a stroke or a heart attack. And some of them say, please bring the heart attack on. I'll be glad to go. So I think you just have to have the conversation, not just withdraw it because you think it's the right thing to do, but do it in concert with a discussion. And it's a good segue. We'll just wrap up by saying, in 2 weeks from now, I'm going to about the withdrawal of ASA therapy. So we have some opinions on that might differ from recent things in the popular news. So we're going to wrap it up and thank everybody for being here in the room tonight, and thank all of you for being with us on the web. We'll be sending out the evaluations to those who are on the web tomorrow, Don? Oh. So those will go out tomorrow for you, and we'll look forward to you. So thanks, everybody, and thanks particularly Dr. Tobe.